So good morning, everyone. It's a real pleasure to be invited to come and speak to you all. Thanks, Prof Quinn and Prof Blencher for inviting me. So what I've been asked to talk about is ultrasound in pre-hospital cardiac arrest. And as you say, it's something which is new, it's technology, makes it interesting. And I think we're all frustrated about the outcomes of cardiac arrest. And so maybe at risk of clutching at straws, looking for things which might make a difference and improve survival from cardiac arrest. So I think it's important that we talk about whether it might be helpful and how we feed it into our overall management of cardiac arrest. But I did need to narrow it down. So my name's Cosmo and I'm a specialty registrar working in anaesthesia, intensive care, cardiothoracic intensive care at the Harefield and at Hammersmith Hospital. And I've also worked for a number of different pre-hospital organisations around the country, teams which respond to cardiac arrest alongside the ambulance service and with you guys. And through that work, I've developed a bit of an interest in the use of ultrasound in both trauma and medical patients, and had some experience of working out how and when it might be useful, and also some of the pitfalls and the difficulties of implementing it, both on scene and in terms of a little bit of a governance structure. So I'm hoping I can share some of my thoughts about how we can use ultrasound in cardiac arrest. And really, I'm going to focus mostly on echo to keep it narrow. But if you've got questions, we can broaden it out a little bit. And then at the end, if there's questions on it, of course, feel free to ask. I'm not linked to any ultrasound organisation. I am not a cardiologist. I am not an echo expert. I think that probably makes it more relevant because hopefully I've got a similar level of echo and ultrasound ability that's achievable to a broad range of people responding in critical care teams or in pre-hospital practice. Because I don't think there's much point in us looking at things that you need an echo technician to do. I think, it's the right kind of level to be working at. So the question that we're all here for the whole of today really is, can we improve cardiac arrest care? And from that, of course, we mean outcomes. And you're going to be hearing about, obviously, the AIRWAYS2 and the Paramedic-2 trials. And these are big, evidence-based, broad treatment effects that we're looking at to improve overall outcome. I suppose the question with ultrasound is, can we do something around advanced therapies and around targeted treatment that might be a little bit more innovative to improve the outcomes in some of these patients? So this is a sort of different way of looking at how can we improve cardiac arrest outcome, and I'll explain that in a little bit more detail. As you all, I'm aware, the outcomes from cardiac arrest are not great, and recent trials and from the AIRWAYS2, neurological survival is poor and is less than 10%. And so that's what we need to think about is what treatments can we do that improve that? And yes, we need evidence and we need these massive trials, and I'm looking forward to hearing about them and about choosing the treatments that we give globally to all of cardiac arrest. But the question is there an area of innovation that we can sort of target, and is ultrasound one of those? And at the end of this, we can decide whether we think ultrasound is going to be an innovative treatment that's going to make a big difference to cardiac arrest. But as I say, ultrasound is a broad church, and we need to focus this down. So we're going to focus it down on echocardiography, and really we're focusing it down on transthoracic echocardiography. In hospital or in cardiothoracics, you can do transesophageal echoes, and they give probably more information and could be really valuable in cardiac arrest in cardiothoracic centres and in hospital. But we need a pragmatic therapy or a pragmatic intervention that can guide the treatments that we give these patients. So we're going to be thinking about TTE, and that's going to be bedside focused echo. And what this is really about is diagnosis. So cardiac arrest is not a diagnosis. It is a situation the patient is in at the end of a severe pathology. And my question is, if we can target our diagnosis more effectively, and potentially if we can use ultrasound to target our diagnosis more effectively, then maybe we can look at improving outcomes in cardiac arrest. So in trauma, we would never think of doing trials on, let's put a KTD on all trauma patients and see if it makes a difference to outcomes. Or the same for blood. Let's give blood to all patients who are in major trauma, ISS more than 15, or in traumatic cardiac arrest, because what we would see is poor treatment effect and harms from that therapy, and we'd struggle to see a benefit. So my question is, do we need to use ultrasound or other techniques to improve our diagnosis and actually split out different types of cardiac arrest? And maybe that is the future of how we improve cardiac arrest outcomes, by focusing our treatment more effectively on the cause of the patient's cardiac arrest. Because certainly in trauma, we wouldn't do broad approaches to our treatment. So scans will give us information, and hopefully they'll allow us to target things better. But when we're thinking about all of this innovation and thinking about these, which are really niche areas in cardiac arrest, we do need to remember the chain of survival and the evidence-based interventions that make a difference in cardiac arrest. And you're going to hear later, of course, great detail on the essential treatments in cardiac arrest and how they're effective and when they're effective. And I think what we mustn't allow is for ultrasound and these niche diagnostic interventions to make a difference to that chain of survival. And there's a temptation for advanced or senior paramedics or critical care teams when they come along to be both distracted themselves but also distract the team who are already on scene from doing the treatments that we know have to happen for patients in cardiac arrest. So it's important that if we're going to use ultrasound, that the impact on those other things is minimal, or we target it in the right patients where we know we're gaining a large benefit for that minimal impact. And there are great resources, there's one from the LAS, which maintain the focus on the essential treatments that need to happen in cardiac arrest. And these kind of resources are going to be key for any teams or any practitioners that want to use ultrasound in their management of cardiac arrest, so that we don't have a leader or a senior clinician being distracted by using ultrasound or echo, and the fundamental important things not happening, and there being a vacuum of power and leadership. So if we're going to use targeted therapy, and if that's our hypothesis, is ultrasound a good or the best way of improving our diagnosis to improve our outcome in patients who are in cardiac arrest? And I think we need to be a little bit careful. I think often in pre-hospital care we do observations, we take BMs, we use our observations and our tests to guide our diagnosis a little bit too much. And it's important to remember that no investigation should be used indiscriminately, and they all have false positives and they all have false negatives. And things such as echo, which are difficult, have a high risk of us getting false positives and false negatives if we use them in the wrong patient. And I'll explain that in a little bit more. So I do believe that we need to improve our diagnosis of patients in cardiac arrest. But this is a key thing. I don't think ultrasound is the main way we do that. I think it may play a part, and I'll talk about it in a little bit. But the key thing, when you come to this cardiac arrest and you're the team that arrives or you're the first on scene, of course that chain of survival needs to start. And the essential ALS interventions and what we do about that, we're going to hear more about later today from these big trials. So that needs to happen first. As well as that, and I think it's something we do forget in cardiac arrest, we should examine a patient. So we need to pick up signs from what's happened to the patient. It's really important in trauma, but it's also important in medical. So if you come to someone in cardiac arrest and they have an old central scar, or they've got puffy edema to their feet and ankles, or they've got a fistula from dialysis, or they've got old injection marks, those examination findings are key to making the diagnosis and targeting our treatment, and hopefully, therefore, improving the outcome of cardiac arrest. So I think examining that patient is actually a slightly separate thing from getting hands on the patient and providing ALS. I think sometimes those two can get blended a bit, and we see that someone's got hands on doing ALS, but no one's actually examined the patient in the traditional sense. So if that can be fitted in, I think that might be an important thing to do, and something for us all to remember, and something that I remind myself. The second thing, and the thing that's probably most important to making a diagnosis in any case, but certainly in cardiac arrest, is someone needs to speak to this man. So this is the man who may know this lady. He may be her partner, he may be her friend, he may be with her all this morning. He may have heard the only thing she said before she collapsed. Our biggest clue to the diagnosis of the person in cardiac arrest is that man. And if we don't have a diagnosis, we're never going to target our therapy. And if we don't target our therapy, I don't believe we're really going to manage to improve our cardiac arrest outcomes. Because as I say, cardiac arrest isn't a thing. It's just a very bad end of the spectrum of whatever your medical or traumatic diagnosis is. So someone needs to speak to him and understand that. And that's going to have to be separate, probably, from the person who's managing the ALS at the time. So diagnosis is key. History is really important in that. Examination of the patient is important in that. And then on top of that, we might get to the point at which we use ultrasound to nuance and refine that diagnosis and either confirm or refuse what we think is the diagnosis and then target our therapy. But my fear is that we do ALS plus echo, which leads to false positive, incorrect diagnosis, and bad outcome for patients. So when your local critical care team, advanced paramedic, specialist paramedic turns up with a whole boot of kit, how will they use cardiac arrest, or how will they use echo or ultrasound in the management of that cardiac arrest? Well, the first thing you hope that they would do, or that any of us would do, is that they would have gone on some relevant training. And there's loads of different training available, and it's open to medics and non-medics and paramedics alike. I think the important thing is obviously to make sure it's one that is accredited with one of the main societies, and there's different courses coming out which are targeted towards pre-hospital and courses which are being targeted to running alongside advanced life support. And then as well as doing a generic course, you can do an in-house course and an in-house training with your kit in your system and starting to simulate and build that into real cases that you're going to respond to. And we did the same down in Bristol, having had most people already gone on a generic course, either a BSc course or a Royal College of Emergency Medicine course. We then did a one-day pre-hospital ultrasound course with scenarios using our V-scans, the kit we use in cardiac arrest, and working those into scenarios. And I think that's a key first step, is that training needs to happen before we go and do it on real patients. The next thing is, remember, we're dealing with patients in cardiac arrest in strange environments, and the guys who teach us maybe on those courses, especially the in-hospital ones, aren't going to necessarily understand the priorities that you guys all understand from the work that you do. But of course, the first thing to do is we're in a difficult environment, sorting out the scene safety, getting the essentials done in the place the patient finds themselves, which is pretty much only CPR and defibrillation, and maybe oxygen in a hypoxic cardiac arrest, and then getting the patient moved before we do anything clever. So once you've got the patient down to somewhere sensible, you're hoping that your critical care team, who've got all the usual kit and also have their availability of ultrasound, are going to be doing the normal things that we want to see in a well-run cardiac arrest, which is obtaining that 360 access, considering offloading the CPR to an automated device, or at least having a plan to make sure that that quality of CPR is good and is maintained and is not interrupted, and providing the advanced life support so that that chain of survival is being rigidly and well put into place with a good team leader, using things like the checklist that we saw earlier that the LAS developed. And then what you really want to see is someone peel away and go and get that history. And I think loads of you guys will have worked with teams that come to help you manage cardiac arrests. And nearly always the best way to work that is for one person to help the guys there managing that cardiac arrest and giving some input but not taking over, and one person to peel off and get that history, talk to that bystander, talk to the guy who understands what happened, and start making that diagnosis. And I think it's then at that point when you come back together, when you've got that history and you've got some idea of what might be causing this cardiac arrest and you've got some hypothesis as to the diagnosis, that is the point to consider, is ultrasound useful at this point? Have I got a diagnosis I want to look for? Have I got a heart that I want to look at and see how it's beating? You need to have something that you're specifically searching for, having done all of that, rather than blindly scanning everyone and hoping we will pick up something, because I think that's the way we're going to get the best benefit from this and the way that we don't interrupt the important chain of survival. So target the right patient and select the right views. And the ECG is going to be important, but that's only one piece of information of the patient. This is kind of how I think about it in my head as to whether using echo in cardiac arrest when we go to cardiac arrest as a team. Sometimes in asystole, but usually I don't. There are reports of patients having ventricular movement on echo in asystole. So I wouldn't say that just because they're in asystole, don't do an echo. So you can do it if you suspect from your clinical findings that the patient might have some movement. That might be signs of life. That might be that there's pupil reactivity. That might be that there's some respiratory effort during your CPR. Of course, the second one, that's the patient we don't really want to see the ultrasound happening, because then we really are getting in the way of treatments that we know work. And even in some of the studies, they talk about some of their scans were done in patients in VF, which seems a little odd. We weren't there, who knows? Maybe they had a shock and then they had an ultrasound scan straight after, or an echo scan. But in my head, shockable, I'm not really interested yet in scanning the patient. PEAs is probably where it's going to be most useful. But again, not in every PEA, just in a patient where you've got a specific clinical question that you want to ask. So this might be one. You see a patient, they've collapsed, they've got some ST depression, their SATS probe is on whilst they've got their CPR going. And then you have the question, reversible causes, thrombus, could it be PE? Is this the question, is this the patient, that we should do an echo on? Should we look at their RV size? Should we look at their contractility and work out from that whether we think the patient's had a PE and whether this is a patient that we should thrombolyse? And I think doing it just from a very basic story and an ECG that shows some ST depression is a bit risky, because you get patients with things like subarachnoid hemorrhages. They've had a spontaneous bleed, they've hit the ground, that's caused pulmonary edema, which has made them hypoxic. So they're hypoxic, they've gone blue, they're in a PEA cardiac arrest, they've got widespread ST changes that aren't regional. And from that, you then put your echo on, and you find that they've got a massively impaired ventricle, and you do a subcostal scan, and you can't compare the ventricle sizes properly because you're doing a subcostal scan. You think the RV is bigger than the LV, and they're in standstill. And you thrombolyse a patient who's had a massive bleed in their brain. And you can see how it could happen, because the information you have and the things you see on the ECG and the scan is then positively identified on the scan, and you give a treatment that you probably wouldn't have given based on just the history and the ECG. So I suppose the point I'm saying there is risk to this, and there is risk to ultrasound, and I feel like I'm being very negative. I think ultrasound can be great, but I just think we need to fit it in to the whole package of high-level cardiac arrest management. Because we have to remember that we're only looking at artifacts and we're only looking at shadows, and half the things we look at on ultrasound aren't even really there, let alone that they're just bad pictures. Half of them are made-up pictures that the computer is generating. And so we have to be really careful that we have a specific question that we're happy to answer with our scan. Having taken all of that into account, let's talk a little bit about how the views and the team might do it. So the best, or not the best views, some of the best views if you can get them, and these are difficult in cardiac arrest, are your parasternal views. I took the view that today was not the day to try and talk or teach how to do ultrasound, certainly not in cardiac arrest, certainly not with no one getting hands on, and certainly not in 30 minutes. But I thought I'd just show a couple of views, because I think it's helpful to see what view you're getting and what angle the probe is doing. And you can see just from that if that patient is having CPR ongoing, it's not going to be easy to get that view, because that probe is exactly where you want to be. But that is a good view for looking at the left ventricle and how it works, and looking for that, when you read in papers, the septal flattening and a high-pressure right ventricle when you do the short axis view in the same place on the lower image. But that's going to be really, really difficult to get in cardiac arrest. And what we don't want to see is that CPR is neglected to get a view that probably won't change our treatment unless we've got a very specific question that we're trying to answer. The top view here, so the image on the top left and the image on the top right, the apical four-chamber view, and that's the view you want to get really if you do want to compare your right ventricle and your left ventricle. That's really the only view you can properly use to compare the ventricle size. Even that is not validated well in cardiac arrest, because the right ventricle, because of its thinner wall, is likely to distend much faster than the left ventricle in standstill. And there's no good evidence that a large RV in cardiac arrest is a positive prognostic sign of something like a large PE. But if you're going to compare the two ventricles, that's the view you need. And again, that's not going to be easy with cardiac arrest going. It's the hardest view to get in a patient, I think, when they're not in cardiac arrest and having CPR. So once the ribs are all moving and the chest is moving, that's going to be even harder. And the bottom one is probably the main view that we're going to look at in cardiac arrest, is the main one to go to, that you can get while CPR is ongoing, have it pre-positioned, and then as soon as there's a pause, look at the heart itself and look for both fluid proximal and distal to the heart, and that's the subcostal view. So those are the main views, but you can see there are some challenges with getting them in cardiac arrest. So remember the CRM when you're running your cardiac arrest, and you can see that the person who's doing the scanning probably can't be the person who's leading the team. And so you either need a two-person team that's a team leader and someone who's doing the echo, or you need really good CRM that you make sure that leadership is being done by one of the paramedics on scene, and the person who arrives with this piece of kit is the person who can then do this scan, look for the information they specifically want to find, and either feed it into the team leader or take back over the team leadership. It's really important, if we're going to do this, that we're familiar with our devices. And the reason for that is you want to set up the correct depth. You want to set up the gain and the settings before the pulse check. And you'll see from a little bit of the evidence in a minute that some of the issues that they've had is time off the chest when scanning someone in cardiac arrest. And we need to minimize that. And the way we minimize it is by being really familiar with the kit so that it's set up well before you even pause the chest compressions. And the other tip would be to make sure you record every scan. And there's an element of that being for governance purposes later. But I think the most useful thing is you record the scan, you get back on the chest, you carry on with your ALS, and then you can sit back for 20 seconds. You can look at the video and you can decide what you think it's showing. Because I actually find it really, really difficult to look at a live image of an echo during a cardiac arrest where they've stopped CPR and try and make a decision whilst you're looking at the image. And if you don't record it, you then can't see it. And I wonder if that's another reason that in the Edinburgh trial that they were having those long times off the chest. So I think it's really important that we have the machine set up well and we know our kit well, but also we record it and then have a look. And that will make the decision making, I think, a lot easier in what's obviously a difficult situation. I think post-return of circulation is probably the best use, or certainly the best initial use, for echo and ultrasound in cardiac arrest, and that's where I found it the most helpful. So after the patient gains ROSC, you guys, I'm sure, are all over the getting them ready, packaging for transport to ED or the cath lab, getting their 12-lead ECG done, sorting out their airway, securing it, considering whether they need an RSI and intubation, starting to think about cooling and temperature management. All that needs to be happening. But during that, there's normally a time, if you're careful about it, to be doing your echo whilst that's happening, or be doing your echo whilst the patient's being loaded into the back of an ambulance and the kit bags are being put on, or be doing it whilst en route to hospital. And I think in that period of time, you can use the echo to guide your post-ROSC care and think about, do they need more inotropes? Do they need dilute adrenaline? Do they actually need more filling and they're underfilled? And you can also get the scans that you couldn't get in cardiac arrest, the other views that will tell you more information, that again you can record and then show to the team leader on arrival. So routinely that's what we would do in Bristol. We would get scans on our way into hospital and then show them to the cardiologist after we'd handed over to the ED team, and that feeds into their decision making about the patient who's going to the cath lab. Normally it's a little bit of ammunition to help you encourage the cardiologist to take the patient to the place you believe they need to go. But I think doing that en route and in post-ROSC is actually quite helpful. It is important, though, and it's really tempting, to stray away from the competency and the questions that you should be sticking to. We're all tempted, I think, to slightly overinterpret the images because you want more information and you want to understand what's happening to your patient that you've invested an hour in. And you hope is going to be a survivor, especially once you've got into hospital with a good output. So I think it's really important to remember, whatever training you've done, whether you've done FEAL, whether you've done FICE, that we stick to those questions when we're interpreting the echo afterwards, both for doing the right thing for the patient, but also medico-legally. I think if we stray too far from that, then we do run into risk. That's the kind of level of quality of image that you tend to get from something like a V-scan en route to hospital. That's a subcostal view. You can see the liver at the top there, the RV and the LV. So they're difficult to interpret. Until you've seen a lot and done a lot, and I still find it difficult, the more you do, the easier it gets. But it's useful extra information in those post-ROSC patients to guide. Do you think there's fluid around the heart? Do you think they need an intervention for that? Are their valves moving reasonably? Are they underfilled? Probably not. Are they overfilled? Definitely not. Are both ventricles moving reasonably? Yes. You can start looking at things like bases and apexes, but that's where the risk starts. And I think all of us, not being expert echo technicians, should try not to do that. The cardiologist will start wanting to look at the regions and what's moving better than other to make the diagnosis. But I think staying away from that is probably the right thing to do. So there is some evidence around echo in cardiac arrest, but it's not strong. The Puka study up in Edinburgh was probably the best and most pragmatic study of actually using echo in pre-hospital cardiac arrest with highly trained paramedics. And it found that the views were possible. Interestingly, it found that mostly they used it to look at patients they wanted to stop resuscitation on. I think that's something that we see quite a lot, is that's when people are tempted to use it, is they're thinking, I don't think this patient's going to survive. I'm looking that there's no movement of the ventricle, and I'm looking to stop. We have to be a bit careful about that because there are definitely reported survivors with good neurological outcome who've had no movement on echo. So it's got to be fed into, again, the history, the patient, the comorbidities, their end-tidal CO2, their rhythm, their downtime. But it shows that it can be done, but it also showed some of the risks, which is that hands off the chest time was long, and it averaged something like 17 seconds, despite the fact they were highly trained, they were being video recorded whilst they did it. And even then, that temptation to stretch out the time is really strong. And it's also been done by emergency physicians, not with timings, but they showed they could pick up a lot of pathology. An important part of doing this is going to be the governance element and how you control that. And this is just one example that we've started to use to try and develop a governance system for using echo in cardiac arrest. And this is one where we just write down when it was, what the patient was, keep the videos, have them recorded, and then through that, whoever your lead for ultrasound or echo or your supervisor is can review each film, and they can compare your interpretation of the film from what they think looking at it. And that can help feed back into a couple of decisions, really. One, were your views any good, and how can you improve them? Two, what was your interpretation of those views, and do they agree with your interpretation of your views? And then probably the third thing is to say, do they actually think that echo was even useful in that patient, and would they have scanned that patient or would they not? And all of that is important to try and improve how we use echo and how we use ultrasound in cardiac arrest. And if you don't have someone who's local who can do that, these are the videos that are embedded. If you don't have someone who's local who can do that, there's actually an online resource you can now do it. So you can have an online portfolio, and an expert can be the person who reviews your scans for you and gives you feedback remotely. It doesn't have to be someone local. So that's probably a good way for getting into it once you've had that initial training and done those courses and done some scanning practice, that you can actually get some remote support, which I think for pre-hospital care would be quite useful. It doesn't replace debrief. It doesn't replace the whole team managing the cardiac arrest. But it's extra information for the debrief as well. So I suppose really in summary, I don't want it to sound too negative, but I just wanted to put ultrasound and echo in context of cardiac arrest and remember that the chain of survival is the most important thing, and those high evidence-based interventions are the most important thing, and we mustn't get in the way of those with equipment and excitement and technology that we're hoping will improve cardiac arrest survival, but there's a risk will actually make it worse. I do think that if we target our care to cardiac arrest better by making a better diagnosis, that might be the way in which we improve the outcomes from cardiac arrest. But I do think the way that we target better and make a better diagnosis is not just through technology. It's 90% through good examination and excellent history taking. And the positive spin to that is you don't need to buy some kit. You don't need your ambulance service to agree to you have it. We can all do that. We can all go out tomorrow and do a better job at making sure someone peels off and gets a really, 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 really detailed understanding of the patient. How were they yesterday? How were they last night? Did they sleep normally? How were they this morning? Did they eat breakfast? When were they first unwell? Was it chest pain first or was it headache first? Did they feel sick? Were they sweaty? If you get a really detailed understanding of that history, I think that's the most valuable thing in figuring out why the patient's in cardiac arrest. And then if we've done all of that, maybe then we can use ultrasound, have it as a tool in our belt, and maybe that will be the little cherry on the cake that makes a difference to diagnosis and maybe one day to outcome. There's a few resources here for anyone who wants to have a look at them, some good ways of gaining extra learning and experience about ultrasound. One of the best, I think, is the Introduction to Bedside Ultrasound, which is a free ebook, which is basically a textbook with videos all built in that teaches you amazing things about ultrasound. So that's really worth a look, and anyone can flick through that when they want. Hocus Pocus is the thing for their online governance and someone giving you feedback. And of course, YouTube can always show you amazing things. Many thanks. Any questions?
Is my mic back on? Great. Thanks very much, Cosmo. Lots of food for thought there. We probably have 5 minutes or so for questions. So who's got a question? Tell us who you are, where you're from, and when the mic arrives.
Yeah.
I've remembered my script here.
Thank you very much. My name's Josh Miller. I'm a research paramedic from West Midlands Ambulance Service. Lovely talk. It sounds like there's still a bit of an absence of evidence of what these patients in cardiac arrest would look like. Is there anyone nationally looking at all of the aggregated registries that you've got on the local levels? And do you then go back and look at the clinical findings at hospital or post-mortem and see what they were to cross against the two expert views, as it were?
I mean, that's what you need, isn't it? Until you start gathering more data together, it's going to be really difficult. I think, as you gather there, because you mentioned post-mortems, the great majority of these patients are not going to survive to hospital. And so, of course, what we want is to find out what the patient died of so that we can figure out whether our presumed diagnosis on scene was correct or not. Now, I've not seen anything about that in terms of medical death or medical cardiac arrest. There's work in London in terms of the air ambulance, in terms of working closely with the coroners to tally up the post-mortem with patients that we treated on scene who died on scene to try and figure out whether we're getting the diagnosis right or not. That's obviously in trauma. I've not seen anything in terms of medical death where we're tying up and getting the results from coroners. There seems to be an issue about information sharing and data sharing and consent for that to happen. And that's been a battle even within a small region and around trauma. And I can only imagine that being just as hard, both nationally and medically. But it's what we want. And if you speak to most families and ask a family, and we talk to our liaison nurses at the Royal London, and every single family who says, we'd really like the post-mortem result, they go, well, I'll send it to you. Of course you can have it. You treated my loved one. Of course you can have the post-mortem result. But getting a body to release it, totally different matter. So that is what we need to make better diagnosis, I agree.
So it's true that, to my knowledge anyway, that no one has systematically looked at the echopathology of out-of-hospital cardiac arrest at scale. The biggest series is the second of those two studies you showed, which is from Frankfurt. Yeah. And that was physicians on a SAMU type sort of thing.
Yeah, in Germany, yeah.
Whatever the German for SAMU is.
Yeah.
And we don't really have enough information on. There's a number of things here. One is, what is the echopathology across out-of-hospital cardiac arrest? Secondly, which of those pathologies are amenable to an intervention that could be delivered pre-hospital? And most importantly, would any of that improve outcomes enough to make it worthwhile having this out there for everybody? Yeah. And you know, those steps, when you think about, well, who's going to pay for this, and the other things that are perhaps more important to do, you know, we need to answer some of those questions.
Yeah. There's a great opportunity cost here, isn't there?
Yes.
To the time and the effort and the intervention and the technology that might be better spent on good CPR defibs and a whole host of other ideas.
So who knows what Buxton's law is? Buxton was a health economist, and Buxton's law is it's always too early to evaluate something new until it's suddenly too late because it's become routine practice. And we see a lot of that in, I'd say, not pre-hospital care alone, but in resuscitation and in emergency care generally. So there are opportunities. Here's a grant application then, Jonathan, where we could look at, and if you look at ECLS, so ECMO, life support, actually there's a worldwide registry. So every patient is on the registry, and there'll be analyses done to help us learn about what's happening and whether it's making any difference. And obviously there'll be trials going on. There are trials going on. We haven't seen any of that sort of thing yet for pre-hospital cardiac arrest ultrasound. And of course, I'm glad you mentioned it because I wrote it down. I thought you've talked about pre-hospital use for diagnosis, and you've talked about post-ROSC. And there was that bit in the middle, which is actually where I think it is mostly used when it is used in pre-hospital care in this country, which is about assisting decision-making about whether to continue or to terminate a resuscitation attempt.
Yeah.
Am I right on that? Because I mean, that's what the ILCOR guidelines, sort of, when you get down to it, say is probably where, in combination with things like end-tidal CO2 and things, where this might be.
Certainly the cohort that don't have movement who are in standstill have a much lower survival to neurologically intact discharge than those who have movement. So it is a piece of information there.
Yeah.